Good morning, everybody, and thank you to the Medical Society. When I learned about the project, it took me 2 seconds to know what I wanted to work on. I'd always been interested in palliative care, and I'm sure, like you, we've experienced certainly an explosion of palliative care, both physicians, referrals, the need. Palliative care became a boarded medical specialty in 2006, although folks could grandfather in up until 2011. And I'll talk a little bit more about that. But I wanted to expand my own palliative care knowledge without doing a fellowship year for a variety of reasons. I love my current job, and I didn't want to exclusively do palliative care, but I knew I wanted to learn more and build on what I had learned in my general medicine residency. And palliative care for all really means all specialties: medicine, surgery, oncology, does a lot of palliative care innately. So how do we define palliative care? Medical care focuses on alleviating the symptoms, reducing the prominence and severity of symptoms. So it's really all about symptoms and quality of life. And that is really the hallmark of palliative care. How do we help people feel better? Which of course is what we're all trying to do as physicians every day. But there is a particular focus, and I'll talk a bit about how when I put on my hat of palliative care, how I do think differently. It's the core of what most of us went to medical school for, is to help improve symptoms and quality of life. And there's a lot of different ways that we can do that in palliative care. So palliative versus hospice, it's one of the probably most common sort of questions. And in this country, we do make a distinction between the two, hospice being a much smaller piece of sort of the broad term palliative care. And palliative care really meant for anybody with serious illness of any sort at any time. Hospice focused on end of life, but palliative care not so much. And palliative care can involve everybody. The patient and the family obviously being the core. Certainly at my clinic, the social workers and PharmDs that I work with have been involved with me in providing palliative care services, nursing, home health aides, chaplains or spiritual counselors. We now have a chaplain intern in my clinic as an innovative way to, again, increase services to folks, and she's focusing on folks with serious illness, sometimes end-stage issues, sometimes just serious illness. So what has happened with the explosion of palliative care? There is a huge workforce shortage. There are obviously, as I mentioned, fellowship programs since 2006. Most fellowship programs have 2, maybe 3 fellows a year, many just 1. And if you look at the capacity building over the course of time, there's only about 1% growth in the next 20 years, because there are roughly 380 fellows that graduate every year, and when you look at attrition and job opportunities, there's just not enough capacity. In 2010, out of Mount Sinai, there was a huge effort to address that, and that was how the concept of primary palliative care versus secondary palliative care was identified. Very similar to, obviously, primary care, for example, for hypertension, dealing with more basic hypertension, and then the nephrologist or the cardiologist, depending where you are, dealing with the more intense or specialized or complicated issues. So that idea of primary palliative care, skills that all physicians need. And again, different if you're an oncologist perhaps, or a surgeon, or a pediatrician, but skills that really all of us got some of in medical school, but some of it has potentially been a bit dormant as we focus on other aspects of care. So what were the primary palliative care skills identified, and what did I focus on my project? So basic pain, basic depression and anxiety, basic discussion of prognosis, code status, the overall concept of suffering. And that is something, I think the concept of suffering is talked about a lot in the world of palliative care, but not as much in the non-palliative care field. I don't think even as a general internist I use the term suffering or thought about suffering a lot, but that word alone has shifted how I think about certain patients. We think often about code status and prognosis along with goals of care or goals of treatment. I recently saw one of our very complicated elderly, about 86-year-old male patients with a lot of medical issues, and talking to him about his goals of care. And he literally just kept saying to me, I just don't want to suffer. And I'll get back to that in a bit, but that was his goal of care. So my project was taking this concept of primary palliative care that came out of Mount Sinai and doing a trial of a non-board eligible training program. And there are other programs across the US, not many. University of Washington, there's one in Colorado, Boston does some. But what I developed along with the palliative care attending, Robin Turner, who I've gotten to know very well, along with all the other palliative care folks from Duke, was I did a year of about 10% of my time working with the palliative care team in a variety of ways. There are certainly other ways to expand palliative care training in a non-board eligible way. There are weekend courses, 2-week-long courses. There are some immersion programs where people shadow boarded palliative care doctors. But what was my project in terms of what did I actually do with that 10% time? And Robin Turner and I developed it together. So I spent time at Duke's inpatient hospice. I would spend 3 to 4 days at a time. And while certainly some of the medical treatments there are things that I'm not going to be able to do in the outpatient setting, I learned a ton about the role of nursing and the way the physicians spoke to those patients and how goals of care were discussed, as well as some real tricks about various medications to use. Duke does have some role in palliative care with their home health and hospice program. So I went on some home visits with the palliative care attendings for those patients. At Duke's fellowship program, I was able to participate in some of their didactic sessions because it's a fairly small fellowship program, like almost all palliative care fellowship programs. Their lectures are small, and I was able to go to some, not all for sure, but some of them. There is an outpatient palliative care clinic at Duke, and I attended that roughly 1/2 day a week on the weeks I was not doing other inpatient hospice. I was able to do some inpatient palliative consults. I essentially learned how their scheduling program worked in the palliative care group, and I sort of tracked which attending was doing what, and just would email them and say, can I round with you next week for half a day? And as I got to know them, it was a great opportunity. I went in some weekends and rounded with some of the attendings. And so that was a great way. As an experienced physician coming in, I knew which attendings I'd already worked with, and I could map out who I worked with. Duke also has a palliative care consult team on the oncology service. And then Robin and I met approximately every other week and reviewed what I had learned and how I was going to bring that back to the clinic. So the symptoms, again, palliative care being symptoms and quality of life. Many of the symptoms are the things you might imagine: pain and dyspnea, opioids being our most potent, obviously, med. And I could talk about that, as Larry knows, for a long time, because I do a lot of work around opiates. But it was great to see opiate use in the palliative care world and how I used opiates. I typically hadn't used a lot of opiates for dyspnea, for example, and now I've done it. So nausea, some of the more complicated medications, as well as anxiety, and trying to distinguish anxiety from pain, delirium and end of life, what medications could be most effective, and depression, how to treat depression with folks with serious illness. And certainly many folks with serious illness have a lot of attention paid to their anorexia or cachexia, and I learned a lot about the role of increased nutrition and what to do. The other big component around palliative care, other than symptoms, is advanced care planning. And again, that alone could be an hour-long topic. I learned a lot and have brought a lot back to our clinic about just initiating the discussion. Like many of you, being busy physicians, it's hard to make the time. And a lot of my teaching and work in my current clinic and what I brought back with me has been just start the discussion. Help the patient pick a decision maker, particularly if there is no adult children or spouse involved. And then really encouraging the patient to talk to their surrogate. As a culture, obviously, we struggle talking about death. And sometimes, we feel like we only have 3 minutes left in the visit, and I work with my residents to say, take that 3 minutes and just confirm who their decision maker is, or just have 1 or 2 points of discussion. Code status is just one piece, as we know. There's so many decisions along the way for folks that are seriously ill, and how can their surrogate really help them? So what services did I provide? So I did a lot of one-on-one visits with patients, both my own and patients that belong to other members of the clinic. I did tours of the inpatient hospice conveniently across the street from our clinic. There's so many rules around hospice. It is obviously a Medicare benefit, and there was a lot of misconceptions, and I had a lot of misconceptions about hospice. So I've just done, frankly, a lot of education about what hospice really means and who qualifies. And recently, a lot of my palliative care work has been in our team meetings where we're talking about our most complex patients, like you all, with Medicare changing their payment and value over volume, how to really take our complex patients and talk about quality of life, symptoms, and what are their goals of care before we embark on a lot of aggressive treatment. So that's been a huge role that I've had. So again, a lot of outpatient referrals from our clinic, reviewing the Medicare guidelines for hospice. And I think one of the biggest effects of my project has been just a clinic-wide spread of using that caring philosophy of palliative care that we all brought with us to healthcare, but sometimes gets lost in our other roles in taking care of patients and worrying about all of our documentation and other tasks, that just having that caring approach. And I'll say to our nursing staff, we have a more palliative focus for this patient who's seriously ill, and that helps to just shift how we are thinking about that patient. Certainly we have gathered data, and we've made a lot of changes around care of complex patients and reducing ED and inpatient stays, and so the palliative care work has worked in conjunction with that. And then lastly, one of the examples of a patient I was involved with over the past year, a 60-year-old patient with severe alcohol use disorder, and I'd known him over the years, although I was not his primary care doctor, and he continued to develop worsening evidence of his alcohol and liver cirrhosis. He was denying that there were really any issues. He would have his ascites drained and go off, and then a week later have his ascites drained again. The staff was very worried that he didn't really get it. I had a visit with him and very quickly was able to help him establish his goals of care, really by just being quiet and doing very little talking myself. And he did, in fact, very much understood how ill he was. And that was just transformative, both for him and the team, because everybody then realized he did actually understand how ill he was. And the focus of his care did shift, and he did die soon after that. So certainly, one of the many lessons I've learned is both from an education standpoint for the provider. There's not a one-size-fits-all approach. There are board-eligible palliative care training, and some people do that mid-career. And then there's other opportunities, some homegrown, like we did at Duke, to establish more palliative care options for patients. And then the care itself is tailored to the specific needs of the patient. That is all. Thank you.